Good day, viewers. Thanks for viewing, liking, and sharing the first video on family planning and contraception, which was used to commemorate the World Contraception Day on September 26. A lot of viewers have been asking for the conclusion, a follow-up to that video. And like I said, that was just an introductory video because family planning as a whole is a very broad topic. It's actually an area of subspecialization in gynecology. This particular episode will be addressing some questions that were asked on family planning and contraception, they've been anonymous in nature, and we're just going to use it for the purpose of our general education. Let me also re-emphasize that family planning is not just a female affair, okay? It's not something which think the whole burden should be borne by women alone. The first question here says, I'm in my early 30s with 3 children, and she's considering bilateral tubal ligation, but worried about reversibility, okay? Well, what she's talking about, bilateral tubal ligation, is one of the surgical options, okay? One of the surgical options in family planning that involves tying of the fallopian tubes, okay? Now, this particular viewer, it shows that she's considering completion of family size. I mean, she has already made up her mind about completion of family size, and that's why she's asking about bilateral tubal ligation. But there are some important things you have to know about bilateral tubal ligation. The word is, it is intended to be a permanent method. Okay, that is the word. In the past, in the consent form, what used to be written was, this is a permanent form, but now it has been modified as it is intended to be a permanent method. Okay, so what that means is that this is not a method for anyone who is not yet sure of completion of family size. Okay, if you are not yet sure of completion of family size, you should not make up your mind about the permanent method. Okay, however, the clause, why I use the word intended, bilateral tubal ligation can be reversed by microsurgical techniques. Okay, but there is no guarantee of pregnancy. That's because even if reversal is done, there are now microsurgical techniques through which bilateral tubal ligation or a tight fallopian tube can be, let me say the word is, you can reconstruct the structure of the fallopian tube using microsurgical techniques, but you cannot guarantee pregnancy. Okay, so that is the modification about the word. And that means if you are not yet sure of completion of family size, you should not think about it. Okay, but if you are sure of completion of family size, there are other things that will be evaluated before you make up your mind about bilateral tubal ligation. The protocol for the consent differs from one country to the other. Some will consider the age, okay, of the woman, the age of the youngest child, the stability of the home, and things like that. Because one of the important clauses in a consent form for bilateral tubal ligation is that you are aware that there are other long-acting reversible methods, okay, that you can use. Okay, your copper IUD can last for 8 to 10 years. Your Mirena can last for 5 years. Okay, there are long-acting reversible methods you can use. Okay, we call them LAC, long-acting reversible contraceptive methods. So therefore, you must sign that, oh, you are aware that these long-acting methods are available, but you choose the option of tying of the fallopian tubes. Okay, so tying of the fallopian tubes is a permanent method, is intended to be a permanent method, and you cannot be guaranteed reversibility in terms of function. Okay, so even though you may read about the fact that there are now microsurgical techniques that can reverse, that can reconstruct a tight tube, even if you can reconstruct structure, you cannot guarantee function. You cannot guarantee pregnancy after. It can be done, okay, after your delivery. Okay, after your delivery, what we call postpartum bilateral tubal ligation. Okay, it can also be done at the interval between 6 weeks post-delivery and any other time in the life of the woman, what we call interval bilateral tubal ligation. Now, this tying of the fallopian tubes can be done at the time of cesarean section, okay? But it is actually not a good practice for you to request for a cesarean section just because you want to have tying of the fallopian tubes done. Because even following the vaginal delivery, you can still have your bilateral tubal ligation done even before you go home. Okay, it's just that the timing differs and the landmark, okay, on the skin where we make such incision is different from those who are having it following delivery and the person who is having it when it's already more than 6 weeks post delivery or at any point in the lifetime of the woman.
3.
The second question from one of our viewers says, I had the copper intrauterine device, copper IUD, inserted 4 years ago. It says, recently I can't feel the thread. Should I be worried? Now, I am aware that one of the things usually instructions offered after insertion of an intrauterine device is for women to feel for the thread from time to time, for them to be sure, as a way of maybe reassurance, whether the intrauterine device is in place or out of place. Well, usually I discourage that practice because a lot of times when some women routinely feel for it, they pull on the thread of the IUD, okay? But for women who have actually mastered the act for a long time, some of them can just feel for it as a way of reassurance. But some other women, or let me say a large number of first-time users, may not know the difference between feeling for the thread, okay, of the IUD and pulling on the thread, okay? You don't want pulling to happen. Now, usually, she said, oh, she can't feel the thread again. Should she be worried? She's anxious. Now, the first thing she is meant to do if you cannot feel the thread of the copper T IUD is to, first of all, present yourself to a gynecologist or a family planning provider who is going to do a speculum examination, okay? Because sometimes from the speculum examination, that thread you said you cannot feel may have been tucked into the posterior aspect of the what we call the posterior aspect of the cervix, or what we call the posterior fornix, okay, so it might be tucked in. That's why you cannot feel for the thread. So the speculum examination might be able to see the thread you are worried about. Now, even if following the speculum examination your gynecologist cannot see the thread, the next thing is actually now to do a scan for you, okay, a pelvic scan for you, okay. This can be either transvaginal scan or a transabdominal scan, okay. Depending on the satisfaction with, sometimes you may have to combine both methods of scan for you to be assured whether it is there or not. And usually now with that, with the on the ultrasound, you'll be able to identify and show you whether the intrauterine contraceptive device is not only in place, is it well placed, okay, in terms of location. Because sometimes you may have instances where you have it has been dislodged to the cervical canal, in which in that case, that doesn't gives a form of reassurance in terms of protection of an unwanted pregnancy. So the next thing your gynecologist is to use a scan to be sure whether. So a lot of times women, instead of pulling or feeling for the thread, they will just come routinely to have a scan done to check whether the intrauterine contraceptive device is there or not. Now that now comes to the issue of whether during insertion, whether they cut the thread. Some will say, oh, some patients will say, oh, doctor, what do you feel about the recommendation about them cutting the thread because if it's too long, my partner might be feeling it and can be discomforting during intercourse. I think the practice differs from one provider to the other. Okay, some prefer to leave the tail of the device long enough so that it will be easier for you to feel. And in that case, sometimes women will come and say the partner is complaining during sexual intercourse and they have to cut short. Okay, I've also seen instances whereby when it was cut short, some women became anxious about not feeling it, or the cut end becoming discomfort. So the practice differs from one provider to the other. Now, what happens in case whereby with your scan, your intrauterine contraceptive device cannot be located in the uterus? The normal location should be within the uterine cavity, within the lining of the womb. Now, we have what we call translocated or a lost intrauterine contraceptive device, which can be outside the uterine cavity. Now, this is not to scare us, it's a reality. The incidence of this is not varies from one practice to the other, but it's not an enough reason for you to get discouraged. There are a lot of women who are actually using the intrauterine contraceptive device and they're happy with it. But I know many of us have asked these questions because you are worried about cases of people where the intrauterine device was lost, moved outside the uterus. Now, in such instances, we have to do an X-ray, okay, to find out whether where it is in the pelvic cavity. Okay, sometimes it might be on the dome of the bladder. The bladder is a place where it actually can be is a common place implicated whenever it is lost. Okay, now so for that the approach now differs. Okay, the approach for removal can be minimal invasive nature, what you call a laparoscopy, to retrieve the intrauterine device. Okay, there have also been instances whereby I've seen a patient that it was during hysteroscopy, which is visualization of the uterine cavity, that the so-called lost intrauterine device was retrieved. So these are the concerns or issues surrounding the issue of lost intrauterine device. Yeah, the third question says, can you expatiate more on the calendar method and the other natural methods of family planning? Natural family planning, you have the fertility awareness method, you have the what I call the lactation amenorrhea method, that is a woman who is exclusively breastfeeding and that's suppressing fertility, suppressing ovulation, and the third one, the withdrawal method or coitus interruptus. So this calendar method you're talking about is just one of the options under the fertility awareness method. Okay, and I said fertility awareness method talks about methods in which you are trying to avoid intercourse when a woman is likely to be fertile. Okay, when the woman is likely to be unsafe. Okay, the unsafe period of a woman. Now, for the calendar method, let me start by saying, if a woman who doesn't have regular cycles, okay, is not a good candidate for using the calendar method. Okay, and the calendar method, you have to know that it fails some people. Okay, and therefore you don't have a high rate of contraceptive effectiveness with it. But why all these methods are important to talk about, like I emphasized, is that there are women who, for their reason of their culture or their faith, will not use any of the modern methods. Some women will not want any device inserted in them or anything, and they may have to use this. Okay, but even with women who feel they are already professionals, or they are experts in using natural method over the years, when you have confidential focus group discussion with some of them, they will tell you that occasionally it fails them. Okay. And therefore, for we people who are not, who don't have regular cycles, you cannot rely on the natural family planning. So I'm going to give an example of the calendar method. If a woman now wants to say, "Oh, doctor, explain to me how to use the calendar method," which is the focus of the question of this particular viewer, you would first of all present to us what we call your menstrual calendar for the last 6 months. That is that in your phone app. Some people have a phone app that keeps records of their menstrual cycle for the last 6 months. So when they meet their gynecologist, it's easier for them to produce. Some also write it down in their paper, or they have a calendar where they circle it for them to know the days of their menstrual cycle from the first day to the last day. So now there's what we call cycle interval. Cycle interval is the number of days between 2 consecutive menstrual cycles. That is, what's the number of days between the first day of one menstrual cycle and the other. That's what we mean by cycle interval. So we take note of that menstrual calendar you have given us of what your cycle has been in over the last 6 months. We take note of what is the shortest and the longest period. So let's say, for example, you have Mrs. Y. Shortest interval is 26, and our longest interval is 30 days. That is the shortest cycle interval she's had is a 26-day cycle, the longest a 30-day cycle. She wants to know how to use the calendar method. Now, what we do is that we subtract 18, okay, from what is our shortest cycle interval. That 18 we subtract is fixed for everybody, okay? 18 from 26, okay? And you subtract 11, okay, from the longest. So the shortest cycle, the interval she has, the 26-day cycle. If you subtract 18 from 26, you have day 8. If you subtract 11 from 30, okay, 30 is our longest interval, we have 19. So between days 8 and 19, she is unsafe. Okay, she's unsafe. That's a fertile period. That's the time in which she should either avoid intercourse or she can use a barrier method of contraception. Either the male use a male condom or the woman use a femidom. Okay, or what we call the female condom. Okay, at that period, there should be no unprotected intercourse between that days 8 and days 19 of the cycle. Now, that is just the calendar method. Under the fertility awareness method, also there are people who also make use of the change in the nature of the cervical mucus. Okay, the change in the nature of the cervical mucus during ovulation from what looks like a thick, sticky mucus to a thin, slippery, transparent nature. Okay, and there are older women who have mastered this over the years, and they will tell you that, oh, they know how to use it. Okay, now for younger women who are not used to, have never used it before, there may be high failure rates if they try to use this as the only method of contraception. There are actually women who will use this method of natural family planning with another backup method. Backup method means, for example, a barrier method. Condoms. Okay, during the time when they feel that they are likely to be unsafe. Okay, and the only time they can have unprotected intercourse is the so-called safe period. Okay, so that's important. Now there are some instances we will combine this change, what we call the symptothermal method. They are combining the change in the nature of your cervical mucus, which you've been feeling over time, with the basal body rise in temperature. Now this basal body rise, this rise in the body temperature during time of ovulation is actually about 0.3 to 0.5 degrees centigrade. So for a woman who doesn't have a personal thermometer and all that, it might have some demerits relying on it. Even the cervical mucus method, do not forget that if there's an infection, a vaginitis, that will affect the quality of the cervical mucus. Even if a woman is on medication for something like cold or a sinusitis, it will dry up the cervical mucus. Okay, so these are things that can affect the quality of the cervical mucus. So it will be difficult for you to interpret these findings with this particular condition. So they are very, very subjective, and if they are going to be used, they should be used up with another backup method of contraception. Now, someone also raised about an issue about post insertion counseling again for implants, that I should emphasize it. And I said post insertion of your implant. Usually, like I said, if you are right-handed, you put it on the left hand, the medial aspect of the upper arm of the left hand, just about 4 finger breadths above your elbow. Now, you shouldn't use that hand to lift any heavy object for about 3 to 4 days. You should keep it dry. You shouldn't use it to bear weights, okay, for the first 3 to 4 days. If you notice any change in skin discoloration or anything after, you should come to the clinic, okay? And if you notice any change in the menstrual, I told you that if you notice any change in the menstrual pattern, especially persistent spotting, removal is not the first line. There are a lot of medications you can be given. I must also add at this point that current evidence says that post insertion of an implant, whether Implanon or Jadel, okay, we advise women to still use condoms for the first 7 days, okay, following it. That is a current modification by a lot of the training bodies on family planning, that now we recommend that women should have a backup method. Usually condoms are given for the first 7 days following insertion. Now, the beauty about implants generally is that reversibility of fertility is very fast, okay? It's not, in fact, if you remove an implant from a woman, that woman can still get pregnant in that same cycle. So you have a very high contraceptive effectiveness rates, and if you decide to discontinue, you are not too worried about, oh, this thing's not going to work in my system for a long time before I get pregnant. Hi, I'm Dr. Temitope Ayomide Akinola, a consultant gynaecologist and obstetrician, a fellow of the West African College of Surgeons, and an internationally certified family planning trainer and provider. I have a strong passion for areas of reproductive health generally. I want just to know that family planning is a collective responsibility. It's not something we should leave only for women to bear. Women go through a lot, from childhood, puberty, the challenges of puberty, the challenges of childbearing, the challenges of menopause, and quite a lot. So we can't leave the burden of fertility regulation alone on them. Now, the new song is now male involvement in contraception, male involvement, okay? We should support them in any method being done, whether the method is going to be solely a female method, or whether we as men are going to make use of the options available to us to support the women. The burden of fertility regulation should not just be left to them alone. We as men have to support the women on area of family planning. Thank you.